Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. I'm your co-host, Ali Khan Lalani, joined by my co-host, Christopher Wallis. Chris, how are you, man? You're looking a little warmer. You're looking more tan. Where did you go over spring break?
Oh man, I don't know that I ever get much of a tan with this pale complexion. We just got back from a little sun and sand with the kids on the beach in Mexico. I imagine you were grinding it while your colleagues were away with family and friends.
Yeah, grinding it and hopefully looking to take some time off. The question is where, and probably anywhere I'm not tariffed, so I'm looking forward to that. But really a pleasure today to welcome a good friend and colleague, Dr. Catherine Zukotynski, joining us from McMaster University, where she's full professor, and the Hamilton Health Sciences, where she's staff in nuclear medicine and radiology. Catherine, welcome to The View on GU. We're looking forward to having you.
Thank you so much for the kind invitation. I'm thrilled to be here.
Perfect. And as you can imagine, this is a hot topic, and we're going to be covering all things theranostics in the time we have as it relates to prostate cancer. So let's start as an introduction, Catherine, to some of our listeners and viewers. Can you take us through what lutetium PSMA means, really what it is and how it works for prostate cancer?
So the idea of lutetium PSMA, as I understand it, basically, is what you're doing is you're making a radioactive drug that has met legal requirements for administration to patients. And in this case, the radioactive component is lutetium or lutetium-177. And the drug component that it's attached to is PSMA. And PSMA is really, it stands for prostate-specific membrane antigen. It's just a type 2 transmembrane protein that's overexpressed significantly in prostate cancer cells. It is expressed in other tissues, but it's vastly overexpressed in prostate cancer cells. So what you do is you design a drug that targets PSMA, where it is overexpressed, and delivers the radiation right to the target. And that's the whole idea behind lutetium PSMA. And what you can do is you can actually image first with a target where instead of delivering, say, a large amount of radioactivity over a small distance, you actually deliver radioactivity that you can image. And so you take a radioactive atom such as F-18 or gallium-68, and you attach that to a target that targets PSMA. And those are your imaging agents.
Yeah, so I think you've already alluded to, one of the really promising things and things that has everyone excited about the idea of theranostics is that sort of imaging-based biomarker, or that notion that we can tie radiologic findings to targeted therapies. And you've alluded to a little bit, but there's a variety of different ways that we can image patients, and there's a variety of different tracers we can use for what is sort of in a broad category of PSMA PET. And can you walk us through what we have in Canada, what we have in other jurisdictions, and maybe considerations we should think about the different tracers as we lean into this idea of theranostic treatments?
So absolutely. In terms of imaging prostate cancer, there are a lot of different ways you can image. So the classic ways are you can image the prostate gland itself using, say, MRI or ultrasound. You can then image the whole body looking for spread of disease, typically using CAT scans or CT scans. Or bone scans. Both of these are ways of looking at the whole body. Another way of looking at the whole body is using a PET scanner. Now, the reason that it's a PET scanner is basically a matter of the radioactive drug that you're using for the purposes of imaging. And then in terms of those radioactive drugs that target PSMA, in Canada, by and large, there's really one that's been Health Canada approved, and that's a gallium-68 labeled PSMA-11 drug. There are other drugs that are available for imaging that are done more on a research basis, and those would be an F-18 labeled DCFPYL, or F18 labeled PSMA 1007. Those are probably the big ones that are used in Canada. In the US, they use gallium-68 PSMA 11. That's been FDA approved. They use the F18 DCF-PYL or Polarify. That one's also been FDA approved. And most recently, Posluma or Flutofulstat, which is also an F18 label, has been approved. I don't know, does that kind of answer your question?
Yeah, absolutely. And so when we use whatever one of these tracers we want, and as a clinician, we're going to order these scans and we come back with these reports that don't quite look exactly like a CT or a bone scan report would look like. We have different measures of uptake or avidity. We have the SUV, means, median, maxes. Can you walk us through what an SUV is and how we should think of these quantitative metrics our nuke med and radiology teams are providing for us?
So absolutely. In fact, the beauty of the reason why nuclear medicine, I think, really took off in recent times is because it's a marriage of both the radioactive drug and the images produced with that and the diagnostic imaging. So for example, when I talk about PET, it's impossible to buy a PET-only scanner these days. It's always either PET-CT or PET-MR. And it's really that you have two different types of imaging that are basically done simultaneously. And then you get the beauty of both. So you can see where are those cells that are expressing the PSMA in the body anatomically. And that's the true power of PET or PET-CT or PET-MR. What was your question again exactly? Take you through the quantitative analysis, I think.
Mm-hmm.
So you can look at imaging and you can look at it subjectively, and then you can try to come up with quantitative measures. When you're looking at something anatomically, you use a ruler basically, and you measure how large is it? What's the density? When you're looking at it in terms of nuclear medicine, you're typically looking at how much radioactivity is being taken up in a certain location or in a certain region of interest. How can you quantify that? Well, you can quantify it using a standardized uptake value. And basically, the idea is they try to figure out how much radioactivity is in that particular area and what's the best way of measuring it. Are we going to take just a maximum? If we drew a region of interest in a particular area, what is the maximum value of activity in any given pixel you could see? Problem with that is you get a lot of noise, and noise is high frequencies and can change your max a little bit. So it makes it a little bit tricky. So they say, well, maybe we should do more of an average, do it over a volume instead of over just, say, one pixel. The problem with that is the way you draw your volumes, the way I draw my volumes, are all a little different. So that introduces errors in and of itself. And then how big a volume do we want? Do we want a mean over a larger volume? Do we want a peak over, say, a smaller volume? Exactly how are we defining it? It turns out that if three of us were to take the tools that we have and to measure our activity, we're most likely to agree on an SUV max, noise notwithstanding, because the noise will be constant for the three of us. And if we can all come up with the same number, it's usually a little bit better than if we come up with slightly different numbers. So that's why, in general, if you read reports for PET-CT, you'll see SUV maxes as opposed to means. In some of the research, in particular with prostate cancer, they have talked about looking at the total burden of disease. So they say, let's actually look at all the disease throughout the body, and let's figure out what the average activity is in all of the disease in the body. It turns out if that activity is very high throughout the body in terms of PSMA expression, then those patients tend to do better with therapy that targets PSMA expression. So that's helpful. The issue is, though, what do you do if some of the disease, but not all of the disease, takes up the radiopharmaceutical? What if you have a spectrum of different prostate cancer disease types? And that's where things get interesting, because prostate cancer, not all prostate cancer is equal. It's a spectrum of disease. It has slightly different genetic characteristics, slightly different PSMA expression, and you can have that whole spectrum in one patient. And that leads to heterogeneity in activity. And so now they've actually started talking about a hit score or a score in terms of heterogeneity. But at the end of the day, I think these are still early times, and we don't know what exactly is the best way of characterizing which patient will respond well to our PSMA targeted therapy and which one won't. And my personal thought is that since prostate cancer is a spectrum of disease, if you can ascertain that you have, say, most of it is expressing PSMA, then maybe your PSMA targeting therapies are going to work really well. But what if you've got a decent population that is, say, not expressing PSMA so well? That in that case, maybe a combination, say some chemotherapy, some PSMA agents might work. What if you have particular genetics that a PARP inhibitor might work well at? So in the grand scheme of things, it's a very heterogeneous disease, and therefore therapy is very heterogeneous.
Great. No, that's excellent. And with that, I think great background. We'll get into a little bit curious about your experience with what it's like for the patient and from the nuclear medicine doctor delivering it. But we'll just take a step back and remind our listeners and viewers, depending on when you're listening or watching this, we might call it Pluvicto, but lutetium PSMA as of this recording is obviously a global option in many countries. Outside US, it's, I think, more than 20 countries at this time. Year to year from 23 to 24, big 30, 40% increases in use. And so we're already waiting for things like PSMA addition and things like that to read out. But if we just step back a little bit and where people might be thinking about using these treatments in their patients, and then Catherine, to come to you for your individual patient experience. But we have, trials like therapy, a phase 2 trial, Vision, phase 3 after ARPI and chemo, and then PSMA-4. Kind of before chemotherapy or after ARPI. To your point, Catherine, these were largely gallium-68 PSMA. Some had looking at uptake greater than the liver. Some had greater than 20 in one disease site. Therapy, I think, used no sites with discordant FDG positive or PSMA negative lesions. And, when we look at the data, very briefly, the hazard ratio, at least for Vision, for an imaging-based PFS was 0.4, and overall survival in that trial was improved. So there's obviously excitement here. Obviously, Catherine, and more proximally in Canada, we're quite happy to be able to deliver this to our patients. But maybe I think some of our listeners and viewers would like to know what your experience is in delivering this treatment to the patient, how they feel just infusion time, how they feel maybe on that day, any precautions or not, and then what you notice in terms of some of the more common adverse events to keep an eye out for.
So I would say in the grand scheme of things, lutetium PSMA therapy is one of the easier ones to give and to receive. It's a total of 6 cycles, typically given about 6 weeks apart. Usually, at least today, we do a one-size-fits-all sort of approach where we typically give a standard amount, and every patient will get the same standard amount, typically every 6 weeks for a total of 6 doses. The injection itself is short. It's usually done over about a 2-minute slow IV push. And often the patient can be in and out of the department within 15 minutes. So people can really run through these therapies very easily. There are other therapies in nuclear medicine where you might have to stay in the department for hours. This is not one of them. This is one of the really easy ones, in my opinion. In terms of how you do, I would say the thing to keep in mind with prostate cancer is, as we know, it likes going to the bones and it loves going to the spine. And therefore, if you consider that you're going to give a fairly high radiation dose to the spine, the thing that I tell people to worry about the most is their bone marrow reserve, and how that will pan out. And therefore, I say your medical oncologist is your best friend. Make sure you follow up closely with them and that you get your blood work, because the blood work in and of itself will be extremely important in telling us whether or not you should get your next therapy 6 weeks apart, whether we may want to change just a little bit So as I said, it is a one size fits all, but we do have a little bit of latitude in possibly pushing the therapy a little bit later, in possibly decreasing the dose a little bit, just to allow for a little bit of recovery. This is an active area of research right now, but I would say still at this particular current juncture in time, there is a little bit of flexibility. And the most important thing is to know that your blood work and everything is in order so that you can tolerate the doses, or that if we have to rescue you, we have the heads up and we know to do it. So the way we're planning on doing it is we do a consultation, usually about 2 weeks before we schedule the therapy. And that's simply because the ordering of the therapy to get it in the hospital takes about 2 weeks right now. They're looking to make it faster, but they haven't quite succeeded yet. So we need to have our consult. We need to know that everything is going to work, or we think it's going to work. Then we have to order it. That usually gives us about a 2-week lead time. The patient comes in. They can come in, basically get their therapy. As I said, it's quite fast. They usually don't have immediate complications. In terms of long-term complications, it's the usual ones. You can get fatigue, you can get dry mouth, you can get nausea, loss of appetite, joint pain, constipation, back pain, and then the decreased blood cell counts, which are the one that I really warn people about. Those are probably the most common side effects. Of course, there are many others, but those would be the most common. Then I tell them that, you know what, we'll probably get you back for blood work in about 4 weeks. And you'll see your oncologist, your medical oncologist, around about the same time. It's nice if we can schedule them pretty much concurrently. So it's a one stop, you get everything. And then based on that, we will plan our next cycle, which would follow 2 weeks later. Usually we try and get the order in on the books when we do the first cycle so that everything kind of goes on autopilot. But we like to be able to confirm that because we know that we have that 2-week window in terms of ordering and getting it. So that's roughly how it tends to run out or play out. And then it plays out for a total of 6 cycles.
Awesome.
But I mean, I think you make it sound very appealing. And I think obviously there's a lot of excitement and interest. And so when we're looking at this, we need to maybe take a step back. You can help us walk through a medical oncologist or a urologist has a patient who's had ARPI, they've received some chemotherapy. What do we need to do from getting that patient sitting in the oncologist clinic to, assessed and ready to have that lutetium injection? What do we need to do in terms of imaging, assessment?
This is a great question, Chris. I mean, I'm happy to because right now we're oftentimes these patients are in the medical oncology unit, and in my other hat as the chair for the GU group, we've had to really, Catherine, haven't we, to kind of really action this in a certain way. So I might give you a little bit of our behind the curtain view of how we tried to launch this locally, and certainly happy to hear we can always do better. And Chris, your experience in Toronto, but at this time, the way we've tried to do it is this: these patients are seen by the medical oncologist post ARPI, post chemotherapy. If these patients are seen and found to be progressing and have not had a PSMA PET scan, of course, that's mission critical to have. It's a key checkpoint to even be having a discussion about lutetium. But many times, some patients have had recent PSMA PETs, and as long as at this point it's within 6 months of that, hey, I think it's time for lutetium, then that's been accepted. But let's assume a PSMA PET scan gets done. At our center, the process flow is kind of a systematic process we've tried to do is to have these patients then referred to be seen or assessed at the GU-MCC or multidisciplinary case conference. And through a lot of behind the scenes work, at least at the Hamilton Health Sciences and McMaster, we have created a new boutique Pluvicto MCC that we call. And these patients will be seen at that MCC. There's a checklist. PSMA PET needs to be on the checklist, ensuring their MCRPC post-ARPI, post-chemotherapy. And that obviously there's been a recent discussion with the medical oncologist with obviously recent blood work that showed the patient be reasonable. At this time, as Catherine's mentioned, these patients are reviewed at the MCC and images ideally reviewed. So you can imagine in a province like Ontario, these images can be oftentimes in many places. And so even the logistics of making sure the images are uploaded locally so we can actually look at it, not just bank on a report, is still a process that needs to be done. But assuming we can see these images, we review it in multi-D setting. And as of this recording, Catherine, we've had kind of our first official, although our second unofficial, MCC more recently, where we had nuclear medicine input, we had medical oncology review, and we obviously had administrative support to check the checklist, check the imaging. Consensus was that this patient would be theoretically eligible. And we have decided that right at that MCC, through our electronic medical record, we would trigger an immediate consult to nuclear medicine, so it's on the books. And then I think the rest, Catherine, you've taken us through nicely, that once that consult is triggered, we're aiming to have the patient seen. We've been very blessed up front, and I can't assume it'll always be the case. We just had an MCC on Tuesday. Patients were already seen by Thursday by nuclear medicine, and infusion already booked within 2 weeks. For those of you listening who are medical oncologists, what we have done in our Epic system is to have an order set where once we get the infusion date, we create a treatment plan. And within that, the week 4 follow-up that Catherine mentioned with the medical oncologist is kind of triggered with blood work, so that there's no misses, there's no gaps. And because 2 cycles are kind of known in advance, we have this patient coming back from medical oncology and already knowing when the next infusion is. And the real trick, which I'm hoping will really play out to actually work well, is that when you see the medical oncologist at week 4, we will have a ready to treat button that automatically speak to the nuclear medicine work queue. So that's how we're trying to communicate without emails, without Epic chats, without texts, just to have it be very systematic. And obviously there's a quality assurance in our any medical corporation, I would think, but certainly our HHS corporation is having a quality assurance to ensure this flow goes well, there's no misses, and people are tracked. So Catherine, I think that's really exciting for us. But Chris, that's how we've been doing it. The reason we decided to make an MCC separately is because you can imagine this list is going to grow. Chris, I don't know what your experience is, but if we do all the patients, Pluvicto and non-Pluvicto, together in one MCC, it could be a lot.
Yeah, we've had, I would say, exponential growth the last few weeks. We had a few of these patients trickling in January, and there'd be one every couple of weeks at an MCC, and that wasn't such a big deal. Over the last few weeks, we've seen that probably the majority of patients in our generalized GU MCC have been there for an assessment of Pluvicto eligibility. So I think we're in the process of moving to a system much like yours. And I think, hopefully we'll be able to branch out and have more centers participating.
Yes.
And so we won't bear the burden necessarily of having to do this multi-D assessment for such a wide geographic swath at each site.
Yeah, it's a good point, because I feel fortunate. I can see Catherine on Tuesdays at 2 MCCs, the Pluvicto and the GU one. But as you say, Chris, many of our centers that currently can give the treatment are responsible for quite a large region. And so we need to roll that out. It does mean there's going to be more medical oncologists talking to Catherine and her colleagues directly, which means the MCC is at this point going to be a good funnel. And then hopefully we have a wave of more centers being able to give treatment, because it's a lot. And we find these slots precious. And Catherine, I don't know if you have comments on what it's like, because nuclear medicine is obviously much more than Pluvicto, but Pluvicto is a big denominator of patients. In terms of like how you plan these precious slots per week of all nuclear medicine type therapy beyond the diagnostics, some of the workflow, HR resources, can you take us a bit about how nuclear medicine anticipates ramping up and being able to deal with what could be, with PSMA4, an even wider eligibility of population? What is it like for the nuclear medicine folks?
So personally, I think you can look at almost any situation and call it either a glass half full or a glass half empty situation. I always try to look at the silver lining and look at it positively. I think that what is happening right now in nuclear medicine is wonderful. I think that it came in the perfect way. I think we could not have asked for a better group of people to be leading the charge than the GU teams across our province and across the world. I think generally, in my experience, GU teams are very well organized. They're very to the point, and they're about getting the job done. And I think that if the floodgates were supposed to come in one particular area, this was the way. PSMA PET is going to do more for PET in Canada than anything else has done for years. Basically, because of the volume of PSMA PET, we are talking about increasing the number of PET scanners across the country dramatically. It's incredible. Now, because of the therapy, we're going to be talking about increasing the therapy and the workforce that goes with that. Not only that, but we know that in GU, we've long had support staff that work in GU, that see patients, that get patients through the system. We're just expanding it now to a therapy that is radioactive. And this is going to get us over the fear of radioactivity, which I think is phenomenal because, it's a wonderful tool in the armamentarium of medicine. I think many of us forget that there were a few interesting things, shall we say, that came out of the Second World War. There was the atom bomb and there was radionuclide therapy, and they came together. The first radioactive thyroid therapies happened around the time of the Second World War. And it took us until now to become front row and center and get on The View.
There you go.
What else can I say?
I love it.
Well, I think that's the perfect transition maybe to the next question, which is, it hopefully won't take us another 50 years to get to the next great version of radioligand therapy or radionuclide therapy. And so, we're talking a lot about lutetium here. That's obviously one way to, deliver radioactivity, but maybe give us a sort of horizon scan as to what you see the next 3, 5, maybe 10 years of radioligand therapy looking at either in prostate cancer or maybe if you have a vision for other sites that our listeners might be interested in.
I think this is just the beginning. I think that what we will see is right now the going will be a little bit hard because it's always hard when you have a big wave and you have a bit of a paradigm shift. But I think that it will ramp up in a beautiful way because the volume will follow. So the volume is basically already here. So now basically we're going to get the staffing. But once you have the staffing and you don't have the fear of radioactivity and you know how to manage it, it becomes much easier to do it with other therapies. Some of the other therapies will take longer. Some of them will be in very, very sick patients. And that will require some fancy footwork. But fortunately, that'll be a variation on the theme. So if it came in with something that is relatively straightforward, relatively easy, relatively, typically a fairly educated population, they know what they want, they know how to go about it. It's a wonderful way to pave that road. So where do I think we're headed? I think lutetium-177, yes, that's a good atom for radioactive therapy, no question. I think there are alpha therapies that are sitting right around the corner. Basically, alpha particles are just bigger than beta particles, and they give off more radiation over a shorter distance. Where will their strength be? They're better at damaging DNA. So if you couple them with something that doesn't allow you to repair that DNA, you might be able to do a whack load of damage in a very small distance. So it might be very beneficial. Now, with great power comes great responsibility. So too will the side effects probably be a little bit more problematic, and we will have to navigate those. I think that the alpha and the beta therapies are coming in prostate. I think they're coming in neuroendocrine. It's just that neuroendocrine is a much smaller population. Prostate is a huge population. I think we're then going to start seeing therapies that will be maybe antibody related, therapies that might be FAPI related. There are going to be new compounds, new targets, new types of malignancies that will be treated. And I wouldn't be surprised if it extends even beyond that, because we know that radioactivity also plays an effect in the immune system. We haven't gone there yet. I think we will. I think this is just the tip of the iceberg, but I think it's a lovely way that will kickstart an entire change in what we are capable of doing and what we will be able to do.
What a fantastic way to give us a sort of wrap on the idea of radioligand therapy. I really want to thank you again for joining us on the VNGU. It's been great to pick your mind and see where this field is moving. I think There's a lot of interest and excitement from physicians, from patients. Certainly, I think this is where we obviously are headed, and we appreciate you getting us up to speed. So on behalf of my co-host, Lalani Wallis, thank you so much again for joining us on the VONGU. And thank you to our listeners and viewers for joining. I hope this has been interesting, informative, and we look forward to seeing you for the next episode.
Thank you.